I will be covering, this is my disclosure to start, and I would like to thank the organizers for inviting me. So what I will be discussing is thrombotic microangiopathy in general. I will be focusing on the Shiga toxin-mediated hemolytic uremic syndrome, the atypical hemolytic uremic syndrome and its recurrence after kidney transplantation, and also will touch base on the thrombotic thrombocytopenic purpura. So I will start by a case. This is a 44-year-old previously healthy woman admitted to the hospital with weakness, fatigue, and malaise for a few days, non-specific symptoms. She had no fever, chills, and no recent travels to any endemic area or any sick contacts. She reports that a week ago she developed some upper respiratory viral infection which resolved in 3 days, which is common in those cases. Any manifestation is usually triggered by an infection. She has no known past medical history, and currently she's not taking any medication. Her physical exam was quite unremarkable except for elevated blood pressure. She had no icterus, no pallor, lungs were clear, heart was normal. GI is normal, skin exam was normal, no rash, and she had a normal neurological exam. On blood work, she had AKI, anemia, and thrombocytopenia. Her creatinine was 3.9 from a baseline of 1. Her platelets were 64,000, hemoglobin 6.8. PT and PTT were normal, and you always should check them to rule out DIC. She had also normal fibrinogen, which support the ruling out DIC. Her workup for anemia revealed an LDH of 648, and aptoglobin was undetectable, and she had a Coombs negative, which rules out autoimmune hemolytic anemia. She had many schistocytes seen in her peripheral smear, and in the hospital, her serum creatinine continued to increase to 8.5, and she was started on dialysis on hospital day 5. Her C3, C4 were normal, ANA and double-stranded DNA were negative, SSA, SSB were negative. This is her peripheral smear, and she had more than 2 of those helmet-like cells, schistocytes, in the peripheral smear on high power field. So this is a simple question, but I just want you to define the syndrome. What entity does she have? Who is with A, autoimmune hemolytic anemia, or B, thrombotic microangiopathy, TMA, or C, hemolytic uremic syndrome, or D, thrombotic thrombocytopenic purpura? What do you think? A, B, who's with A? B, C, D? Okay, so the right question is, we're dealing with thrombotic microangiopathy. So the TMA syndromes are extremely diverse syndromes. They could be hereditary or acquired. They could affect children or adults. They are associated with this microangiopathic hemolytic anemia characterized by anemia, low aptoglobin, high LDH, and positive peripheral smear for schistocytes. The pathology usually shows arteriolar and capillary microthrombi and severe endothelial injury. On this picture here, you can see there is severe, what we call endotheliulosis, which is swelling and proliferation of endothelial cell filling into the lumen and occluding the lumen. Not only the endothelial cells are activated and swollen, but even the myocytes also starts replicating and putting layer after layer. This is what we call the onion skinning on the kidney biopsy when you look at those arterioles. And also the lumen and the walls are filled with fibrin, suggesting that there is microthrombi developing into those arterioles. So there's many syndromes that could cause thrombotic microangiopathy. What I will be focusing on today are the hereditary and the acquired TTP, hereditary and the acquired complement-mediated TMA, and the Shiga toxin-mediated hemolytic uremic syndrome. So when you see a TMA, we all should think TTP, and that's easy to rule out by checking a ADAMTS13 level. If your ADAMTS13 level is less than 10%, you are dealing with TTP. But if your ADAMTS13 activity is more than 10%, you almost rule out the possibility of TTP. We also should always think of, are we dealing with atypical hemolytic uremic syndrome, because special treatment is required and as soon as possible. Otherwise, we'll end up with end organ damage, essentially renal failure. But there is many other causes of thrombotic microangiopathy. By far, the most common cause of thrombotic microangiopathy is malignant hypertension. This is what you're going to see in the emergency rooms, and this is what probably you will be asked on the board also. But there is, non-Shiga toxin-mediated infections, parasitic infections like Plasmodium, vaccinations, cancer, metastatic cancers, pregnancy associated with a lot of TMA. Post-transplant TMAs are quite common. They're often mediated by drugs. And, some cobalamin, some vitamin deficiencies, severe pancreatitis, and many, many drugs on the market could be associated with thrombotic microangiopathy. Be aware of the calcineurins after kidney transplant. Sirolimus after kidney transplant can cause TMA. Cisplatin and gemcitabine used for the treatment of cancers are commonly asked about on the boards as causes of thrombotic microangiopathies, and the treatment is withdrawal of the agent and supportive care. I will continue with the case. Patient underwent a kidney biopsy on day 5. This is a normal glomerulus. You can see the capillaries widely open, happily looking glomerulus. And this is our glomerulus on this patient. All the capillaries are filled with microthrombi. And when you look at the electron microscopy, she has severe swelling of the endothelial cells. Plasma exchange was started on hospital day 5, and her hemodialysis also was initiated. The features of MAHA, or what we call the microangiopathic hemolytic anemia, persisted despite 5 days of plasma exchange. Her ADAM-TS13 level or activity came back, not level. The activity came back and is 78%. It's normal. And she had negative antiphospholipid and negative Shiga toxin test. Those are rapidly done in the hospital. So what is the best next step? Would you continue with plasma exchange for another week? Oh, I'm sorry. I gave you the answer. My apology. So the next best step is probably to consider Eculizumab, because it seems here we have an infection-triggered thrombotic microangiopathy with really no features to support TTP or Shiga toxin, and almost ruled out every other potential secondary cause. So probably most likely we're dealing with atypical HUS, and on your practice, this is how you're going to make the diagnosis on clinical grounds, because testing takes a lot of time to come back. Before administration of Eculizumab, what should you do? Would you vaccinate the patient for Neisseria meningitidis? Vaccinate the patient for Neisseria meningitidis and start at least 2 weeks of antibiotic prophylaxis for Neisseria with ciprofloxacin, for example. Monitor for any signs of meningitis and treat as needed. No further intervention is needed, just proceed with Eculizumab. Who of you would do A or B? So it seems everybody is with B. So yes, this is a black box warning. Eculizumab could cause fulminant and deadly Neisseria meningitis by Neisseria meningitidis or meningococcus. So vaccination is required. And because there is a need for a time for the protecting antibodies to develop, you have to prophylax with antibiotics for at least 2 weeks. In certain countries in Europe, they continue antibiotic for the life of Eculizumab exposure. So in summary, you're dealing with a patient with thrombocytopenia, microangiopathic hemolytic anemia, organ failures, either neurological, renal, or gastrointestinal. First, reflex, evaluate for ADAM-TS13 activity and do a Shiga toxin test. If your ADAM-TS13 activity is less than 10%, I would say instead of 5%, you are dealing with TTP, take the patient to plasma exchange. If your Shiga toxin is positive, you're dealing with the STEC HUS, and this is supportive care, as we will see. And if your Shiga toxin is negative and your ADAM-TS13 activity is more than 10%, you're either dealing with the complement-mediated HUS or secondary form of TMA. While you're waiting, in some centers, ADAM-TS13 takes time to come back, and while you're waiting, for ADAM-TS13 activity, if your platelet count is more than 30,000 and you have severe renal failure with a creatinine of more than 2.3, you can almost certainly rule out TTP, because it rarely causes severe renal failure, and usually platelet count is much, much less than 30,000. So you can feel kind of certain that it's not going to be TTP. So hemolytic uremic syndrome comes in 2 forms. Either it's diarrheal mediated, and this is usually induced by the Shiga toxin, which is produced by a special strain of E. coli, and most cases usually recover spontaneously, or it could be complement mediated, and we'll talk about that in a second. So the Shiga toxin, HUS, is usually induced by either E. coli, infection with enterohemorrhagic E. coli, or Shigella, and usually the contamination is via water, vegetables, beef products. It's usually common in children and can cause severe AKI. 6 to 9% of STEC-infected children develops HUS. Not everyone will end up with hemolytic uremic syndrome, only a minority of, of those infected children. Usually there's a prodrome of bloody diarrhea for 5 to 10 days. 60% of the patient will develop renal failure requiring dialysis, and usually they need up to 10 days of dialysis. 25% of affected patients will have neurological symptoms, and those are the severe cases. 4% could die. 5 to 25% will have long-term disability and morbidity after the STEC with hypertension, proteinuria, or a reduced GFR. The treatment is supportive. There is no treatment. And plasma exchange has been used. Even Eculizumab has been used in cases with severe neurological manifestation, but the utility of those approaches is still uncertain. So what happens? You get the infection in the intestine with Shiga, with the E. coli secreting Shiga toxin. Shiga toxin makes it to the bloodstream. It's carried to the kidney and other organs by leukocytes. On the endothelial cells and the glomerulus, there's those GB3 receptors which bind the Shiga toxin in red, and then the Shiga toxin is endocytosed into the endothelial cells, fuses with the endoplasmic reticulum, and the toxin is released, and then it's resecreted in the ribosome, attaches to the ribosome, and block protein synthesis. So the cell cannot generate any new protein. It becomes inflamed. It's procoagulant, and microthrombi occur diffusely wherever the toxin makes its way, essentially in the kidney. Which one of the following statement is correct? We're jumping to another category of disease. Normal complement levels rule out atypical HUS. The absence of complement system-related genetic mutation rules out atypical HUS. The absence of family history of atypical HUS rules out atypical HUS. None of the above. Excellent. So atypical HUS is not induced by Shiga toxin. It's often recurrent, and 50% of patients have normal complement level during the severe manifestation of the disease. They even 50% have normal soluble MAC on their peripheral blood. It may cause permanent kidney damage, may cause neurological and other organ damage. Lungs, heart could be affected, GI system. Frequently recurs after transplant and may be sporadic or familial, and it's usually linked to abnormalities of complement regulatory proteins. So this is the complement. We're not going to cover the complement. We're not going to talk about the classical pathway or the lectin pathway, but we need to touch base a little bit about the alternative pathway. As you know, the alternative pathway of the complement is constantly active in all of us. Every second, the complement is sticking and generating C3b and C5b and C5a and C3a and C3 convertases and C5 convertases. And the reason for that is to be ready to protect us against any invasive bacteria, virus, and to defend us. But why we don't develop atypical HUS? Because we have tons of regulatory proteins that quickly decay those damaging proteins that are produced constantly in our body. The main factors are complement factor I, which is a serine protease that can decay and degrade any active complement protein in the alternative pathway, even the enzymes that generate them, like the C3 convertase and the C5 convertase. Another regulatory proteins is complement factor H, thrombomodulin, MCP are both glycoproteins expressed on the surface of the endothelial cells, also help in the decay of active complement. So imagine we don't have those breaks on the alternative pathway. Those are the patients who are going to develop atypical HUS, and they need a trigger. The trigger is usually an infection, a pregnancy, a surgery, a drug exposure, and this is what trigger the superactivity of the alternative pathway to overcome the available breaks, and the disease would manifest. So mutations have been described in almost all those regulatory proteins. The most common one is mutations affecting complement factor H. They constitute almost a quarter of the mutations, and they are concentrated in the C-terminal part of factor H, which is the part required for binding on the surface of the endothelial cells. Other mutations in factor I have been described. Activating mutation affecting C3 and complement factor B also have been described, rendering them resistant to the decay activity of normal complement factor H and complement factor I. Again, those two proteins, thrombomodulin and MCP, are expressed on the surface of the endothelial cell, and they also help in the degradation of complement active proteins. They could be mutated also and cause atypical HUS. In some patients, there's no mutations in those regulatory proteins, but there is antibodies that could bind, for example, to complement factor H and block its activity, and this by itself could trigger, in the right setting, atypical HUS. 50% of the patients have no identified mutations. So what happens? C3b is divided to C3b and C3a. C3a is a potent anaphylatoxin. C3b, degrades or decay factor or cut factor B into factor big B, little b, which binds to C3b, and this constitutes the C3 convertase, which feeds back into generating more C3b and more C3b, big B, little b, or the C3 convertase. Further, the cascade goes down, C5 convertase is generated, and then you have the membrane attack complex generated, which damages the endothelial cell. And this damage leads to the formation of microthrombi. And when those RBCs try to squeeze themselves between those microthrombi, this is how you get the schistocytes. So this is, in a nutshell, the pathophysiology of the disease. Not all mutations are equal. Complement factor H is well known to be the most severe, leading to end-stage renal disease more frequently than, for example, MCP mutation or any of the other mutations. Not all, there is an incomplete penetrance. Look at this family, 2 kids at very young age developed atypical HUS and died from atypical HUS carrying a well-known mutation of complement factor H. Their brother developed atypical HUS at age 40 years and ended up on dialysis. Their father carries the same mutation, never manifested the disease, but their grandfather at age 82, carrying the same mutation, developed atypical HUS and died from atypical HUS. So you can see the high variability on the expression and the disease manifestation. We don't know why. So this is a little summary that deficiency or dysfunction or autoantibody-mediated inhibition of one or more of the regulatory proteins of the complement alternative pathway could lead to atypical HUS. It could also, atypical HUS could result from resistance of C3b or factor B to the decay activity of factor H and I. Some mutations of thrombomodulin or MCP, which are endothelial glycoprotein, could also lead to atypical HUS. But this is the most important thing. The disease may be quiescent for months or years, even in patients with homozygous mutations and complete deficiency of regulatory proteins, and only to be triggered by an otherwise innocuous infection, drug exposure, or pregnancy. So, as I said, the most important piece of the complement activation is the generation of the membrane attack complex that is going to perforate cells and really cause the injury. So if you can block C5 from splitting into C5b and C5a, you can block the membrane attack complex formation, and we have a drug that does that. The drug is called Eculizumab, and it's a humanized monoclonal antibody that binds to C5 and prevent the splitting of C5 into C5a, C5b, blocking the formation of the membrane attack complex, protecting the cell from the damage by activated complement system. So this is a more, the same Eculizumab, and it was trialed in patients who are resistant to plasma exchange. Those are patients who are known to have atypical HUS, and they were maintained on plasma exchange, and they were not responding to plasma exchange. 100% of those patients had a GFR less than 60, and on the trial, on Eculizumab, at the end of the trial, there was an increase by 32 ml in their GFR. 4 of 5 patients were able to stop dialysis. And when they looked at the patients who are less severe, they have atypical HUS, but it is much less severe. It was responsive to plasma exchange. Even those patients benefited by a slight increase in their GFR. But when you look at the quality of life, rather, getting an infusion every 2 weeks or being on plasmapheresis 3 or 4 times a week, you can see there's a great increase in quality of life. And based on those trials, FDA approved Eculizumab as the treatment of choice for atypical HUS. Black box warning is the meningitis risk. Patients should be vaccinated for Neisseria meningitis before using Eculizumab. And if you are using it emergently, you have to prophylax them with antibiotic for 2 weeks or even for life in some countries, especially in Europe. Disease could recur after transplant, and the recurrence rate is quite high, and it leads to graft loss in 75 to 100% if you do not treat and prevent it with special drug like Eculizumab. MCP is a special case. You know, MCP, I said, is an endothelial protein expressed on the surface of the endothelium. So if you transplant a new kidney with a normal MCP, you should cure the disease. Despite that, 15% of the patient could still recur. And the reason for this is that 25% of patients who have MCP mutations have mutations in other regulatory proteins. So this is why I think prior to transplant, genetic testing is very important to rule out, to know what kind of mutations you're dealing with. So what about Eculizumab after transplant? It has been used, and this is the French data, and it has been used in this category of patients as an alternative to plasma exchange that was failing in almost 13 patients. And these are the characteristics of the patient. Most of them already have been transplanted before, and they lost the graft to recurrent disease. 12 of them had mutations in the complement regulatory proteins, identified mutations, and 12 were totally dependent on plasmapheresis, and they were resistant, and 1 could not tolerate it. So what happened? You can see after Eculizumab, platelet count improved. This is on plasma exchange. Creatinine was high. It dropped after the initiation of Eculizumab, and platelet count improved. The microthrombi that were present at the manifestation of the disease, they disappeared at 12 months, and C5b, C9, or the MAC, deposition in the kidney also improved on Eculizumab, and creatinine improved from 3.9 to 1.77 on the drug. So it definitely works, and it works better if you use it earlier. You can see in red are all the patients who received Eculizumab before 28 days. They have almost complete recovery of their graft function, as compared to the patients who were started after 28 days. There was not a full recovery of their graft function. So use it, and use it early. If you know your patient has a typical HUS, you should probably prophylax them with it. And this is what this study showed. The patients who were preemptively treated with Eculizumab at time of transplant, none of them developed thrombotic microangiopathy lesions, and none of them had a recurrence of the disease. And this is the protocol, how to use Eculizumab. And living donor, it's recommended that you start a week before the surgery. Unfortunately, you cannot do that with deceased donor. So they got a dose at time of surgery and a dose the second day. And then you give weekly doses, and then you spread it to every 2 weeks. When do we stop the treatment? It's unknown. It's unclear. And I hope this is something we'll be able to answer quite soon with the ongoing trials. So this is a new case. This is a 12-year-old male patient who developed end-stage renal disease secondary to atypical HUS. He is now undergoing an evaluation for kidney transplantation at your center. Which of the following statement is correct? Living unrelated kidney donor should be avoided. Living related kidney transplant should be avoided. He can be transplanted regardless of the source of donor as long as he receives Eculizumab after kidney transplantation. The risk of recurrent atypical HUS after kidney transplantation is very low. Who is with A, B, C, and D? Okay, so the right question is B. And the reason for that is highlighted in this case report. We try to avoid accepting donors from living-related recipients, a living-related donor for recipients who have a diagnosis of atypical HUS. In that case, this is a kid who developed end-stage renal disease from atypical HUS. He received a kidney transplant from his father, and 1 year later, his father developed atypical HUS. So those mutations could run in the families, and sometimes it's so hard to find them. They could carry another mutation that the recipient does not have. So it's recommended to avoid or accept live donors from a related donor. Eculizumab is not the only solution for to transplant a patient with atypical HUS, ESRD secondary to atypical HUS. Most of those regulatory factors are generated by the liver, so you can perform a kidney and a liver transplant and hoping that the new liver will provide them with new complement factors that could be protective and curative for the atypical HUS. So this is a 10-month-old male infant who presents with MA, thrombocytopenia, and AKI. It's 10 months old, so this is one of the highlights of the case. He has no known family history of atypical HUS. The patient had persistent hypertension, hematuria, and also nephrotic range of proteinuria, which is unusual with atypical HUS. All genetic complement testing for atypical HUS were negative, and he had no circulating anti-complement factor H antibodies. C3 and C4 are also normal. A kidney biopsy was performed, and definitely you can show for here, you can see here there's a thickening of the glomerular basement membrane, and there is severe swelling of the endothelial cells, almost total occlusion of the lumen of the capillary, suggestive of thrombotic microangiopathy. What is the most likely diagnosis? Complement-mediated atypical HUS, TTP, HUS secondary to deacylglycerose kinase epsilon mutation, or lupus nephritis. Who is with A, B, C, and D? So the right answer is C. So this is a newly identified mutation responsible of almost 30% of atypical HUS before age of 1 year old. And characteristically, those patients develop also, a lot of time, nephrotic range of proteinuria. It is unrelated to complement. Eculizumab will not treat it, and usually it does not recur after kidney transplant because the kidney transplant provides a normal DGKE to protect the transplant kidney. So, how are we doing on time? Okay. So TTP, it was described in 1924 by Moskowitz, and it is associated with central nervous system involvement. For a long period of time, we did not understand the pathophysiology of TTP, and we were able to see that those patients have those large von Willebrand multimers circulating in their blood, and they were identified on many biopsies also. So the TTP is characterized by this pentad of severe thrombocytopenia, the MAHA, neurological involvement, could be headache, seizure, confusion, TIAs, renal failure, and fever. If you have the pentad, you can be almost sure that you're dealing with TTP. So von Willebrand factor is usually synthesized as dimers in the endoplasmic reticulum, and then it's transformed into multimers in the Golgi apparatus, and this is how it's secreted, binds to the endothelial surface, and it's this multimeric form that is the active form. But thankfully, we have ADAMTS13, which usually cleaves it on constant base and deactivate it so we don't clot and we don't develop platelet activation and microthrombi. The hereditary thrombotic form helped us to understand the pathophysiology of TTP. So this is the rarest form of TTP where you have complete absence of ADAMTS13 due to a mutation affecting the gene of ADAMTS13. The syndrome is called Abschow-Schulman syndrome, and it causes TTP either at very young age or even it can start in adults, especially during pregnancies. Patients who are heterozygous for the mutation do not have the disease. So 50% of activity of ADAMTS13 is enough to protect us from TTP. And this is, these are the pictures of the von Willebrand factor cleaved by the ADAMTS13. And you can see if ADAMTS13 is absent, microthrombi would develop because those multimers are persistent and can activate the platelets and lead to platelet thrombi. In the acquired form, there's no deficiency of the protein itself, but we develop antibodies against ADAMTS13 that could block its activity. And it's only when the activity is less than 10% that the disease could manifest. And here, the same pictures, but showing you the antibodies that could either block the activity of the ADAMTS13 or even accelerate its decay, leading to the disease manifestation. The treatment in that case is to do plasma exchange, and definitely plasma exchange changed the field of TTP. Without a plasma exchange, mortality rate is more than 90%. With plasma exchange initiated early, survival is more than 90%. You can also use some immunosuppressants to target the autoantibody to eliminate it. You know, the plasma exchange will do that, but you can use steroids, you can use rituximab in severe or resistant cases or even relapsing cases. Adults with TTP, as I said, would go onto plasma exchange. I already discussed this. Steroids are also frequently used. Rituximab could be used. Aspirin and anticoagulants should be avoided because of risk of bleeding. Severe thrombocytopenia is sometimes treated with platelet infusion. You should see here, the study is quite interesting. Patients who had very low activity of ADAMTS13, less than 10%, when they were treated with plasma exchange, their survival was 93%. Patients who had ADAMTS13 activity more than 10% and they were treated as TTP, their survival was very low. So always think of other etiologies or other possibilities of TMA other than TTP when your ADAMTS13 activity is high, more than 10%. And those treatments we already covered. So I'll go through this case and I'll be done. 35-year-old female with no past medical history presents for 5 days of headache, nausea, vomiting, and non-bloody diarrhea. No recent travel. Husband and kids are healthy and ate same food. Has never had this constellation of symptoms. Medications, none. Past medical history, 3 full-term vaginal deliveries, no miscarriages, occasional alcohol, no tobacco, no illicit drugs. Her family history, father has hypertension, CAD, and siblings and children are all healthy. She was slightly febrile, heart rate 90, and slightly elevated blood pressure, setting fine. And she's 60 kilograms, no apparent distress. She was a bit pale, lungs were clear, heart is normal, abdomen was diffusely tender with deep palpation, but no rebound, no edema, no rashes, and she had no neurological focal deficits. Creatinine was 2, BUN was 36, platelets are 30,000, LDH 1800, and aptoglobin undetectable. She had normal amylase, lipase, and LFTs, and her urine was positive for red blood cells and white blood cells and several granular casts. Blood and urine culture is negative, stool culture negative, and STEC was negative. INR is normal, PTT is normal, ruling out DIC. Sample sent for ADAMTS13 activity and antiphospholipid antibodies. What is your first therapeutic approach? Plasma exchange with steroids, plasma infusion, steroids and rituximab, or eculizumab? Who is with A? B? C? D? Excellent. So this is the right choice. Plasma exchange initiated with fresh frozen plasma replacement. There was a rapid improvement in headache. Platelet count improved to 180 by day 4, and LDH dropped to normal levels, almost normal levels. On day 5, prior to plasma exchange, platelets dropped to 140, LDH increased to 480. Return of headache and less than 10-minute episode of left-sided weakness. She had a TIA. ADAMTS13 by day 4 is returned, and it's less than 5% of normal, confirming TTP diagnosis, and there was an inhibitor that was identified. What is the best therapeutic approach for this refractory TTP? Increase the dose of PEX to twice daily, continue current dose of plasma exchange, and high-dose steroids and rituximab given at end of plasma exchange. Give eculizumab, reconsider your diagnosis. Who is with A? Who is with B? C? D. Okay, so the right answer is continue current. You know, increasing the plasma exchange to twice daily has been studied. It really does not contribute a lot. But if you continue with plasma exchange, high-dose steroid, and you add rituximab, there is a great number of people who might respond and eliminate the autoantibody and recover the activity of ADAMTS13. What is the best treatment for the first relapse of acquired TTP? It usually occurs more than 30 days after recovery. After an initial good response to plasma exchange and steroids during the first presentation, would you restart plasma exchange and steroids? Would you add rituximab to the plasma exchange and steroid? Would you perform splenectomy, or would you consider cyclophosphamide? Who is with A? B? C? D? So the right answer is, again, plasma exchange, steroids, and rituximab. So rituximab, I want you to know, is becoming more and more used for the treatment of relapsing or resistant cases of TTP. I think I'm done.